Welcome to Chapter 17 of Diabetes Canada 2018 Clinical Practice Guidelines, Weight Management in Diabetes. I'm Dr. Sean Wharton, the lead author of this chapter. My co-authors are Dr. Sue Peterson, Dr. David Lau, and Dr. Arya Sharma. The key points from this chapter and the changes from the 2018 guidelines are as follows. The preferential terminology to use when discussing weight management is patient-first language, using terminology such as people with overweight or obesity in place of overweight or obese people. This is an effort to decrease bias and stigma, as people living with overweight and obesity are not defined by their weight, but instead they are struggling or living with this condition. There's also new information on effective pharmacotherapy for chronic weight management. We will also look at the effects of bariatric surgery in people with diabetes and obesity, and there's now longer-term follow-up. Obesity is a growing epidemic. We know that 80 to 90% of people with type 2 diabetes have overweight or obesity. We also know that some antihyperglycemic therapies contribute to weight gain. There is evidence that higher BMI increases mortality, but there is good news. We do know that weight loss of just 5 to 10% can improve glycemic control. We can classify obesity using the BMI classification, or body mass index. Underweight is classified as a BMI less than 18.5. This, in fact, puts individuals at an increased risk of developing health problems. Healthy weight is defined as a BMI between 18.5 and 25. This is the BMI that puts patients at the least amount of risk. Increasing risk develops with BMIs above 25, as we see in the overweight category, a BMI between 25 and 30. Obesity is defined as a BMI greater than 30. Class 1 obesity is a BMI between 30 to 35. The risk is now high. In Class 2, a BMI between 35 and 40, the risk is very high. And as we move into Class 3, a BMI greater than 40, the risk is extremely high. Further measurements besides BMI can be taken to assess the risk of developing medical complications in patients living with overweight and obesity, including waist circumference. We can also look at other comorbid conditions such as hypertension, dyslipidemia, and cardiovascular disease. When looking at waist circumference, there are cutoffs. For men, a cutoff of greater than 102 centimeters puts an individual at increased risk of developing health problems. For women, the cutoff for waist circumference is greater than 88 centimeters. That puts them at an increased risk. There are ethnic-specific values for waist circumference that put an individual at increased risk. These have been defined by international guidelines and by Health Canada. The values are seen here in this table. In patients living with diabetes, weight management and weight loss is achievable with appropriate intervention. Our first goal is to prevent weight gain. After that, we want to promote weight loss if it is needed. After the weight has been lost, we want to prevent weight regain. The good news is that weight loss of 5 to 10% improves insulin sensitivity, glycemic control, blood pressure, and triglyceride levels. Adjustments in medications may be needed to get us closer to our goals. This can include decreasing weight-gaining medications and potentially adding medications that promote weight loss. Here are the primary treatment strategies for people living with diabetes, overweight, and obesity. The overriding and cornerstone treatment is healthy behavior interventions. This includes diet, activity, and psychological treatments. Next, there's pharmacotherapy. And finally, there's bariatric surgery. Healthy behavior interventions include a combination of an appropriate diet, physical activity, and behavioral therapy. Structured interprofessional programs are recommended, and group programs work best. Dietary plans should be evidence-based and nutritionally adequate. There's evidence that carbohydrate reduction can be beneficial. Appropriate physical activity is an essential part of behavioral interventions. The goal is to have a reasonable weight loss of 2 to 4 kilos per month. Pharmacotherapy for weight management has been quite promising in recent years. The indication for pharmacotherapy is for patients with a BMI greater than 30 or a BMI greater than 27 with comorbidities in whom healthy behavior interventions have been unsuccessful or insufficient for improvement in health. These agents can improve glycemic control and can reduce doses of antihyperglycemic agents that promote weight gain. Here are a list of the medications approved for the treatment of obesity in type 2 diabetes. The first agent is a gastrointestinal lipase inhibitor called orlistat. The relative weight loss is minimal. The side effects include loose stools, GI upset, and rare liver failure. Therapeutic considerations include the fact that it is an oral medication, it decreases fat absorption, and it may require vitamin supplementation. There is a cost to this agent. The second agent is a GLP-1 receptor agonist called liraglutide at 3.0 milligrams. The relative weight loss is moderate. Side effects include nausea, GI upset, rare gallstones, and pancreatitis. The therapeutic considerations include that it is a subcutaneous injection and it increases satiety. There is also a cost to this agent. When choosing antihyperglycemic agents to treat diabetes, there should be a consideration in regards to the weight effect of each of these agents. There are a number of agents that can cause weight gain, which may be an undesirable effect for many patients. This includes agents such as insulin, the TZDs, sulfonylureas, and the metaglutamides. Medications that are weight neutral or can in fact decrease weight include metformin, alpha-glucosidase inhibitors, DPP-4 inhibitors, GLP-1 receptor agonists, and the SGLT2 inhibitors. Bariatric surgery can be an important option for patients with diabetes and obesity. The criteria for bariatric surgery includes patients with a BMI greater than 40, or patients with a BMI between 35 to 40 with comorbidities, the primary one being type 2 diabetes. When it comes to the control or remission of type 2 diabetes, we see that this is higher with the Roux-en-Y gastric bypass, the gastric sleeve, and the BPD compared to gastric banding. After surgery, it is important that clinicians follow their patients over the long term and screen for reoccurrence of diabetes, especially if there is weight regain. Bariatric surgery is inadequately studied in patients with BMIs between 30 to 35 and in patients with type 1 diabetes. Here is a graphic representation of the types of bariatric surgeries that are used to treat type 2 diabetes. This includes the gastric sleeve, the Roux-en-Y gastric bypass, and the biliopancreatic diversion. They all have their advantages and disadvantages, and this is best discussed with the bariatric surgery team. Here's a checklist for patients who are looking for an appropriate weight management program. The highlights of this checklist include the program should assess and treat comorbid conditions and not just look at weight loss. The program should recommend healthy behavior modifications and pharmacotherapy or surgery for those who qualify. The program should provide individualized nutritional, physical activity, and behavioral programs and counseling. There should be a reasonable weight loss goal. Costs should not be prohibitive. There should be no requirement to buy products, supplements, vitamins, or injections. The program should not make unsubstantiated claims. And the program should have access to a weight maintenance program. The first recommendation from Chapter 17, Weight Management in Diabetes, states, For people with overweight or obesity who have or are at risk for diabetes, an interprofessional weight management program is recommended to prevent weight gain and improve cardiovascular risk factors. This is a grade A, level 1A recommendation. Recommendation 2. Weight management medication may be considered in people with diabetes and overweight or obesity to promote weight loss and improved glycemic control. This is a grade A, level 1A for liraglutide and grade A, level 1A for orlistat. Recommendation 3. In adults with type 2 diabetes and overweight or obesity, the effect of antihyperglycemic agents on body weight should be considered when selecting pharmacotherapy. This is a grade D consensus recommendation. Recommendation 4. Bariatric surgery may be considered for selected adults with type 2 diabetes and obesity with BMI greater than 35 when healthy behavioral interventions with or without weight management medications are inadequate in achieving target glycemic control or healthy weight loss goals. This is a grade A, level 1A recommendation. Here are the key take-home messages from Chapter 17, Weight Management and Diabetes. First and foremost, sustained weight loss, and not just short-term weight loss, but sustained weight loss of greater than 5% of initial body weight can improve glycemic control and cardiovascular risk factors. Next, let's look at the 3 treatment areas. First, healthy behavior modifications. In people with diabetes and obesity, weight loss and A1C lowering can be achieved with healthy behavior interventions, and this is the cornerstone of overall treatment. Weight management medications are also beneficial. They can improve glycemic and metabolic control in people with diabetes and obesity. Bariatric surgery has its place and may be considered for appropriate people with diabetes and obesity. Next, we have to consider the effect of medications, antihyperglycemic medications, on weight. So when selecting the most appropriate antihyperglycemic agent for persons with diabetes, the effect of weight should be considered. Some agents can cause an increase in weight, some can be neutral in weight, and there are some that can actually decrease weight. Further key messages for people with diabetes. When you have diabetes, having overweight or obesity increases your risk for complications. Healthy behavior modifications, including regular physical activity and eating well, can help with your blood glucose control and reduce your risk for other health problems associated with diabetes. Your diabetes healthcare team can help you with weight management. For some people with diabetes, weight management medication and bariatric surgery may be very helpful. The full guidelines, interactive tools, and other useful resources can be accessed on the guidelines website, guidelines.diabetes.ca. The information is also accessible on the Diabetes Canada app, available in the App Store and for Android. Thank you for taking the time to listen to this information from Chapter 17, Weight Management and Diabetes, from Diabetes Canada 2018 Clinical Practice Guidelines.